Good afternoon and welcome to our webinar series. And this is the Secure webinar. Provide us the welcome and opening remarks. We have ADB's Poverty and Social Protection Specialist who has 25 years of multidisciplinary human and social development experience in East and Southeast Asia and the Pacific, including 20 years within the Asian Development Bank. She looks after a portfolio of ongoing human and social development operations and policy dialogue in 22 countries. This includes support for primary healthcare in Indonesia, to improving upper secondary education in Cambodia, and introducing community-based aged care in Tonga. She has worked in the fields of various countries, including Cambodia, China, the Philippines, Ukraine, Indonesia, the Lao PDR, Mongolia, and Vietnam, among others. Let us all welcome Ms. Karine Schelse.
Greetings and welcome to the webinar series on Driving Change, Conversations on Transforming Primary Care in Southeast Asia. Primary care is the foundation of a robust healthcare system and plays a vital role in ensuring the health and well-being of our communities and in achieving universal health coverage. Primary care is the first point of contact for people and for families for preventative and curative health services, and it plays a critical role in pandemic preparedness and response, as we witnessed during the COVID-19 pandemic. As our developing member countries in both Southeast Asia and the rest of the Asia-Pacific region implement primary care expansion and reforms, they face a lot of challenges. For example, shortages of qualified healthcare providers, especially in rural areas, create geographic disparities in access. Fragmented financing mechanisms can leave vulnerable groups struggling to afford essential services. Vertical or standalone disease programs can result in inefficiencies and a lack of coordinated care. Finally, the increase in non-communicable diseases like diabetes and heart disease, along with rapid aging, requires innovation in primary care interventions. The ADB has been supporting developing member countries from the Greater Mekong subregion to Indonesia and the Philippines to address these challenges and build better and more resilient health systems by providing expertise and resources. We believe that countries' investments in primary care will not only improve individual well-being, but will also contribute to economic growth and social stability. This has never been more pronounced than during the pandemic, where strong primary care systems played a crucial role in stopping the spread. We're particularly pleased to host a webinar series that will share country experiences in transforming primary care systems. Today we'll hear from Indonesia and in the coming months from Singapore, Thailand, and others. Over the next few sessions, leading experts will discuss lessons and issues including expanding access to essential services, particularly in rural and underserved areas, fostering innovative models of care delivery, including private sector engagement and contracting, strengthening primary care workforce development, and harmonizing different sources of funding for primary care to promote transparency and accountability. We hope this series will pave the way for future collaboration, allowing us to collect and share best practices, identify solutions together, and shape the future of primary care in the region. So please do participate in the discussions throughout the series, ask questions, share your experiences, and engage with your fellow participants. Thank you very much.
Thank you very much, Karine, for providing us the welcoming remarks. So to proceed, let me introduce to you the Secure webinar. So the Secure webinar series facilitates knowledge and information exchange among Southeast Asia governments, the private sector, the development partners, CSO networks, and other key stakeholders. So what we have right now as the first webinar of our four-part series on driving change, conversations on primary care transformation in Southeast Asia. This is the 13th Secure webinar that will discuss the progress and challenges of the ongoing primary care transformation in Indonesia. So here, we will get to examine the experience of two decentralized East Asian countries, not just Indonesia, but also of the Philippines, but with a focus on the experiences of Indonesia. Indonesia will provide us the perspective of how their reforms are meeting the requirements of the health sector in implementing primary health care. The Philippines and Indonesia experienced exponential increase in the amount of per capita for healthcare in the recent years, and both health systems, the two countries, has a mix of public and private, facilities operation. And in these two countries, we both have experienced devolution or decentralization of its healthcare in the recent years. The literature around health decentralization in developing economies has been limited, and there is no widely accepted health policy framework for decentralized settings. And the learning that we can get from the experience of Indonesia would provide us an understanding of how we can stimulate the conversation, provide policy and implementation frameworks that can happen also as well in the Philippines. And some interesting facts that we will later hear about is how Indonesia has shaped its health social security implementing agency. And of course, a very interesting topic around special allocation funds. So I'm encouraging everybody who's attending this webinar to ask questions, provide your insights, and use the chat button and provide us, and we will provide us your insights, and we will be collating these insights, and we will try to cover these in our question and answer portion. After we will have the panel of experts and panel of speaker from the Philippines provide their insights from the presentation. So for our first presentation, our first speaker is a lecturer in global health at City University of London since 2022. His interest in global health, health systems and health reform, policy impact evaluation and NCDs, built environment and geospatial analysis has provided him his career trajectory. Before City University, he was a researcher at Imperial College London, working on a project aimed to reduce the burden of diabetes and cardiovascular diseases in South Asia. He was also a researcher at Harvard University, where he conducted a comprehensive assessment and designed an impact evaluation of the enhanced primary healthcare intervention towards tackling CVDs and diabetes. He obtained his PhD in global health from Harvard, Masters of Public Health from the Royal Tropical Institute in Amsterdam, and a Bachelor of Science from the to discuss the delivery and financing of primary healthcare in Indonesia. Let us welcome Dr. Dian.
Thank you so much, Dr. Michael. Let me share my screen. Right. Thank you so much for the opportunity to share the findings for this project. So I'll be talking about the delivery and financing of primary healthcare in Indonesia in this session. So this will focus on, first we'll cover the delivery of service delivery part, and then the financing part. It'll be the focus on primary healthcare government facilities in Indonesia. So the first part will be on health service delivery at the district level. And I'll be talking about district health offices, Puskesmas, which is the government public health center. And under Puskesmas, I'll be showing what are the networks of services, and that includes direct network and also indirect network. So indirect network is mainly provided, mainly led by the community, and direct network is led by the government. And now in terms of district health office, there's one in each district, and there's about over 500 districts, which includes cities or regencies in Indonesia. And in terms of the accountability of the district health office, is led by the head of district health office and is accountable to the mayors. So in all the delivery, service delivery, and the financing side that I'll be talking in the next few slides, we are focusing at the district level here. So in Indonesia, we have the national level, we have the provincial level, which is about 30 or 34. And then after that, we have the district level. And then this district health office is accountable to the mayor of each district. There's different types of district health office. It could be type A, type B, type C, depending on whether the district has small, medium, or large workload that's usually reflected in the number of populations of the district. And in terms of responsibilities, district health office is responsible for the primary health services. And so that includes primary in terms of individual care and also public health, public health services. And they're also responsible for the referral health services at the district level, within the district, and also beyond the district, for instance, at the provincial hospital or something. And then licenses for hospitals, only for hospitals classes D, C, and D, and other local health facilities within the district. So district is just really the one who's responsible for the health sector. Now, this is just to give you a sense of the distribution of the district in Indonesia, and this is based on the Rifascas data, which is in 2019. This is the latest that was available. Rifascas is health facility survey. So it's more like a census. So basically, all the health facility, especially the government health facility, is surveyed, and then data are collected. So we have in here to 2019, we have 514 number of district, and so that's why we have 514 number of district health office. And then out of that, about this is the percent. So about 60% or is type A, and then about 40% is type B, and then only a small fraction is type C. District health office, and this is to show that the workload of a majority of the district is large. Now, this is just to give you a sense of the structure of the DHO or district health office in type A. So this is the large workload. You have the secretariat, which is covers program, public relations, finance, assets, and legal, and also human resource, HR, and then there's also public health division. So and within the public health division, the subdivision include family health and community nutrition, health promotion, community engagement, environmental health, occupational health, and also sports. And then they have division for disease prevention and control, which includes subdivisions like health surveillance and immunization, infectious disease prevention and control, non-communicable disease prevention and control, including mental health. And then they have the division for health service or service delivery, which includes primary health care. So this division is usually the one who's supervising the puskesmas, because primary health care would be under that. And then also referral health services. For instance, if the district has their own hospital, like district hospital, so that hospital sometimes would be under the district, or it could be under the mayor directly. So, but the referral services within the district would be under the, under the responsibility of this division. And also traditional complementary medicine would be one of the subdivision. And then we have the division of health resources, which includes pharmaceutical like drugs, and also health equipment and supplies. Dealing with the equipment for the district health office itself, or the puskesmas or pustu, all the government clinics under the district health office would be under this subdivision, for instance, and also, of course, human resource for health. So this is a kind of type A. The difference with type B and type C is usually some of this subdivision is combined because their workload is less. This is just to give you a sense of how comprehensive is the responsibility of district health office, and I would imagine it's similar in other settings like the Philippines. Now, puskesmas this is the government clinic, government health center. The regulation, in terms of the regulation, the puskesmas must be established in every sub-district. So this is to say that every sub-district usually has at least one puskesmas or one public government health center. Although under certain conditions and depending on the needs, population, or accessibility, it can be more than one puskesmas. So in cities you will likely find that in one sub-district they will have 2 or 3 puskesmas instead of just one. Now, accountability, they're led by the heads of puskesmas as is accountable to the DHO, District Health Office, yeah? And then, as you remember, District Health Office is accountable to the mayor. So this has changed the dynamic in terms of who they report to, what they're accountable for. So before there's a decentralization in the form of the evolution in Indonesia, the health sector, Ministry of Health is responsible all the way down to the puskesmas and district health office. But after decentralization and evolution, it's now that the district government is sort of they are accountable to the district government instead of the central Ministry of Health. Now let's take a look at the responsibility of puskesmas, which is the government clinic in each sub-district. They do public health services. Public health services, so UKM is the public health services at the first level, at the primary level. Yeah, so this includes health promotion services in the sub-district, environmental health services in the sub-district, family health services, and also nutrition services, and also disease prevention and control. And then also individual health services, and this is a big part of what the clinic is doing. Individual health services at the first level, and this is carried out curative services carried out by doctors, dentists, and other health workers with the authority based on the regulations, yeah? Which so this includes outpatient care, like both health visits and sick visits. Also emergency services and also normal service delivery, and this is depending on whether or not the puskesmas has the capacity to have a normal delivery services. Also, they have some home care visits, for instance, also hospitalization based on consideration of the need for health services. So there are a wide range of capacity of puskesmas in some big cities, for instance, or big puskesmas. They're able to have some inpatient visits and also normal delivery, for instance, but in other type of puskesmas, smaller puskesmas, they don't have that capacity. And then guidance for primary healthcare facilities in this area. And this is to show that puskesmas is also sort of supervising or overseeing the other primary healthcare facilities, whether it's government or non-government. Yeah. And this is again to give you a sense of distribution for puskesmas. As you see, this is the number of DOH, Dinkes DOH, and then that is based on the number of district per province, right? But the number of puskesmas, for instance, there are provinces, depending on the number of district, there are provinces like West Java here. West Java has over 1,000 puskesmas. But there are also newer provinces or smaller provinces like this one, North Kalimantan, who only have about 50 or less than 100 for Gorontalo and West Sulawesi, just to give you a sense of the diversity and the different numbers of puskesmas distribution. And then we talk about that's the structure, what they do in terms of what they do is something to do with minimum standard of services. They call it SPM in Indonesia. It's a mandatory provision of basic services that every citizen has the right to obtain. And this is based on the Ministry of Home Affairs regulation. Yeah, so this is the regulation and the guidance for SPM. So this is the guidance for minimum standard of services at the province and also at the district level. And this is not just for health, but for all the basic services, not beyond health. So there are 6 areas, including education, health, public works, public housing, peace, public order, community protection, and also social. Yeah? Now, at the district level, there are 29 SPM indicators, including 12 that are health indicators that are shown here, and is very comprehensive in terms of what it covers. It covers women's health, service delivery, maternal, and then newborn health services, and also under 5, primary education age, health services for young adults, elderly, people with hypertension, diabetes, and everything. So there are specific indicators that is within this Ministry of Home Affairs regulation. Yeah? Now, this is just to give you a sense of the distribution of the health workers by characteristic. And so at the Puskesmas level, for instance, this one, if you look at so on the left one is the medical doctors and dentists, and the right one is nurses and midwife. So this one is the urban, perkotaan, and pedesaan is rural. So if you see the average, the number of doctors is higher in urban, 3.26, the average in urban per Puskesmas, and then also in terms of in the rural is 2.1. Dentist is even more concentrated at the urban level, almost double the ratio between urban and rural. But is the other way around for nurses and midwives, for instance, in for nurses and midwives, the average is higher among rural Puskesmas, which is about 13 nurses per Puskesmas, compared to 12 in urban areas. And midwife, which is bidan, is also even higher, higher average, about 17 midwife per Puskesmas in rural areas, compared to about 14 or 15 at the urban. So this is to show you the distribution by urban and rural, for instance. Now, we talk about DHO, we talk about Puskesmas, which is the government clinic, and now we talk about the direct network under Puskesmas. So the direct network include Pustu, which is auxiliary Puskesmas, Pusling, which is a mobile Puskesmas, and Polindes, which is a village midwives. Right. So all of this is an integral part of Puskesmas. So if you imagine there's one government clinic at the sub-district level, for instance, so under that Puskesmas, there will be these other networks. And so they need regular supervision and development by the Puskesmas. So they literally like branches of Puskesmas. The main aim is to increase the reach and quality of services for the community under that area. Pustu is usually one for 2 or 3 villages or wards. So villages is at the regency, and wards is usually used at the city, but both as at the district level. So one Pustu for 2 or 3 villages, and under certain condition, it can be, including the needs, and it can be one Pustu in one village or ward, yeah, and this condition is determined by the district health office. And then in terms of the role of Pustu is literally extending some of the roles of Puskesmas, like increasing access to primary health services, supporting the implementation of public health services, implementation of posyandu activities, and we'll come to posyandu in the few next slide, in terms of immunization, MCH, family planning, and others, and also supporting referral services. So it's basically supporting everything that Puskesmas is doing. And again, this is just to show you a distribution of that by province. So Pustu is here and at the end. So you've seen this Puskesmas. We have about almost, in 2019 at least, almost 10,000 Puskesmas, and then they have 25,000 or almost 26,000 Pustu. Yeah, so it is so many. And then another direct network is Polanders or village midwives, and this is the midwifery service. So if Push2 is also covering other than midwifery. Midwifery is sort of Polanders is focusing on usually on midwifery services, and it's usually done led by midwife assigned to a village or sub-district within a working area of Puskesmas, and the role includes maternal health services, child health is there as well, reproductive health and family planning, and also others that is assigned by Puskesmas. This is to show you the distribution of Polanders. There are places like provinces like West Java and Central Java has over 2,000 Polanders, and East Java has more than 4,000 Polanders, for instance. But also, other like Jakarta only have 3 Polanders, for instance, and also smaller provinces like North Kalimantan has 29, for instance. Yeah, so just to give you a sense. Now, indirect network of Puskesmas, we have Posyandu integrated services post by the community. So this is indirect because it's led by the community, and ideally, at least based on the definition, Posyandu is not just covering health, but in practice, the main area that is usually doing health is at the neighborhood level. So it's even lower than ward level. So we have the sub-district, we have the district, sub-district, ward, and neighborhood level. So this is at the lower level even. And then to synergize the services needed by the community, including health, food security, and social welfare and others, yeah. For Posyandu that is focusing on health, here are some of the main activities that they do in the event. And then this is mainly on maternal and child health, but more recently, they're also Posyandu for elderly and also for detection of non-communicable diseases. Now, this is just to show you again the distribution by province. Overall, the number of Posyandu is more than 300,000 in 2019. And then also for elderly is more than 100,000. And then the portion that is focusing on non-communicable diseases is more than 70,000 in Indonesia. Reporting is one of the main thing that the government has done in terms of, and this is reporting using the website. Yeah. It is spm.kemkes.go.id. Kemkes is the Ministry of Health, government.indonesia. This is one of the layout if you are looking at from the district perspective. And this is to show you what, in terms of your target for pregnant women, how many you do it in a year. And in terms of target for infant or for 1-year-old or under 5, how many that you are targeting. So everything is imputed in this, and this is an SPM application that is, or website that is led by the Ministry of Health in this case. Right. So the second part of my talk will be on the spending at the district level, on the financing. Yeah. And we'll be discussing about 2 things. One is the special allocation funds, which is called DAK, non-physical for health. Right. So and then the second one we'll be talking about BPJS capitation for primary health care. Yeah. Now the first one, special allocation funds, DAK non-physical. Yeah. So the definition first, this is a national budget that is allocated directly to the region. So the region here could be province, it could be district, and to help fund operational activities. Note here that the underline is operational because this should be non-physical. Yeah, it cannot be used to build a clinic, for instance, or to renovate buildings. It has to be non-physical. It has to be operational. And for the DAK non-physical for health, it will be in health sector in accordance with the national priorities. And then the other name for so DAK for health, another name for it for health is also BOK, which is health operational assistance, because the DAK for health is non-physical. It's not just for health. There also be DAK non-physical for education, for others, so many other sectors. And health is just one of them. And BOK is the Fund Operational Expenditure for National Priority Program for health services and Puskesmas. So the work plan, so it has to be a bottom-up work plan is prepared by the District Health Office together with Puskesmas and approved by the Ministry of Health. And at the Ministry of Health, these are the parties, the Directorate General that are involved in this in the use of this funding. Now, you see in the definition, the DAK non-fiscal for health is focusing on national priorities. So these are the national priorities, right? In Indonesia, improving life expectancy, reducing maternal death, child health, child stunting, and others. Also, infectious disease in terms of tuberculosis, Indonesia, in terms of the numbers, the second highest in the world, and the proportion of death due to infectious disease is higher than the regional average in Southeast Asia. And also the prevalence of smoking among adults 15 plus, for instance, was highest among the countries in the region. So these are some of the national priorities to be supported through the special funds, non-fiscal for health. Some of these four main challenges in improving primary health care in Indonesia. Human resource is generally lacking. These are some data, for instance, 50% of Puskesmas in Maluku and Papua, which is in the eastern part of Indonesia, has no physicians. Also 60% of Puskesmas has no labs, and 33% has no pharmacies. Yeah, so these are, and the quality of health services is poor. Drug and health equipment are not adequate, and Puskesmas budget is not enough. And then, so all of this reason to help revitalize primary health care, including through DAK non-physical for health in terms of their operational budget. Now, in terms of how it's allocated, there are four types of how to use the special allocation funds for non-physical for health. One is you put it at the provincial level, which would include activities like reducing maternal mortality, infant mortality, early detection, and others, pharmacy and procurement, hospital accreditation, and training and capacity. Yeah, and in terms of the district spending on district, it's also similar to the province. Essential public health, like reducing maternal mortality, infant mortality, nutrition, and also early detection and response, and then pharmacy and medical consumable, and also quality of regional labs, improving quality of primary healthcare services, and others. They're working with health workers, health cadre, and everything. So and the third part is supervision for drug and food at the district level. It's something that you can use the money for as well. And a big chunk of the non-physical, the DAK non-physical for health, is provided to Puskesmas, which is the to also in terms of the focus of activity, reducing maternal mortality, health, additional food. So this is supplementary food, providing incentive, also internet packages for Puskesmas, and also calibration of Puskesmas medical equipment. You see, now in terms of the amount of allocation, they're calculated according to a formula by considering the criteria. I don't have the formula here on the slides, but it's in the report, is a bit more detailed. But in general, the amount of allocation would depend on the general criteria for formulated based on regional financial capacity. There are also special criteria based on the regional characteristic. There's a regional weights and also regional characteristic, based on the district and city status. Also technical criteria in terms of considering in the health and actual budget absorption. It include the data sources considered of health sector indicator, and also other data. And there are also even consideration for new autonomous region, especially in the eastern part of the Indonesia. For instance, they have a different different sets of formula in terms of allocating the special fund. Now, in terms of the distribution, the transfers of fund, the poor province, it's directly from National Treasury, General Treasury account to the provincial General Treasury account. So it's directly to the province. For the district funds, they're going all the way to the district General Treasury. For Puskesmas, even they're going directly to the Puskesmas account, and especially if the Puskesmas, is in the BLUD status, which I think I will touch a little bit later. And the distribution is carried out by the ministry that's carried out the government. So this is to say that it's carried out by the Ministry of Health in this case, and recommendations are made based on the reports of utilization. So it also depends on how the Puskesmas, how the district utilize the funding the year before. Now, this is just to show you the absorption, the utilization of. So this data was until mid 2022. So that's why the absorption for the realization for 2022 is not high. But if you see if other countries like the Philippines is considering to do something like this as well to support the primary healthcare at the district level, one of the things that needs to be in mind is these, at least the data from Indonesia is showing that the absorption is usually some of the issues. Like in this case, the absorption is 80%. This is 77%, and this is also about 70%. Yeah. So there is an effort. There are efforts that needed to improve the absorption of this special allocation budget. Now, before I go to the app, just to give you a sense that within the special allocation fund, non-fiscal for health, more than 95% is allocated to the district and Puskesmas. So as you see, the four types of use: the province, district, drug supervision, and also Puskesmas. Basically, the funds mainly are used either for district or Puskesmas. Now, this is an application again, e-Rangar, which is the planning and budgeting application managed by the MOH, which the district and Puskesmas has access to in reporting their use. So all the reporting will be done through here. And this is a sample. If you're looking at the so you can click on which menu in terms of whether this has something to do with pharmacy, with a mobile clinic or lab or something like that. Is it's already there's sub menu as well, sub item here, which you can just click and put in your target, your plan, your budget, and everything like that in terms of reporting. Right. I think the second part of the financing part is the BPJS capitation. The BPJS is the National Health Insurance Agency. Capitation payment for PHC, for primary healthcare. Now, capitation payment, monthly payment paid in advance to primary healthcare facilities based on the number of registered members. So this is monthly payment and paid in advance to Puskesmas, for instance, based on the number of registered members, without taking into account the type of amount of health services provided. So based on the registered members, regardless of how many health utilization was done, the Puskesmas is getting a certain amount already in advance. In 2021, we have over 10,000 Puskesmas contracted by BPJS, the agency, yeah? And a majority of the Puskesmas is something called BLUD. So this is like a public delivery agency status that they have. So the difference with between BLUD and non-BLUD is that with BLUD they have like semi-autonomous status, where the funding from the national government from BPJS at the national level can go directly to Puskesmas instead of going to the district health office. Yeah. And then in 2020, among 224 million of BPJS members, almost 70% is registered at Puskesmas. Yeah, so this gives you the sheer number of Puskesmas members that are also BPJS members. Of total BPJS capitation, also again almost 70% is paid to Puskesmas because 70% members are registered at Puskesmas. This is the standard capitation rate at the Puskesmas level is between 3,600 to 9,000 per BPJS. So that's 3,000 is about 11 Philippines currency. That is per participant per month. And then if you are a hospital or independent practice or dental practice, you have a different amount. Yeah. Now, capitation rates criteria, they have I don't have a detail here in the slides, but I have it in my report. The capitation rate criteria includes human resource, availability of doctors and dentists, completeness of facilities, what type of facilities and infrastructure that you have at the Puskesmas, the scope of services based on the risk and age, sex of the registered participants, and also service commitment based on performance, level of participant visits to your facility, optimizing gatekeeper, promotive, and preventive. There are special capitation rates, especially in remote areas. For instance, the special capitation disregard the risk and performance criteria. So in remote areas, they mainly focus on, so they disregard the third criteria, isn't it? The risk and age three and four. The scope of services and service commitment is disregarded. Instead, they have a set, other set, which is like a Puskesmas, for instance, which as a doctor will be given 10,000 per participant per month. So instead of 3,000 to 4,000. And then the PHC, the Puskesmas only has one midwife. We have about 8,000, and the facility with less than 100 registered participants, the rate is paid for 1,000 participants. So imagine if you are a small clinic with only less than 1,000 registered BPJS registered participant, you will be given at least 1,000 per participant for the capitation. Yeah, the flow of fund again with the BLUD. Puskesmas is more flexibility in financial management. It has like a semi-autonomous status, so it will be a direct transfer from BPJS to Puskesmas. And then Puskesmas non-BLUD is a bit more time is needed because there's no flexibility in financial management at the Puskesmas level, so it has to be transferred to the district health office or district general fund even, and then they have to follow the local process, the financial standard, a standard financial management at the district level. So more time is needed if you are not a BLUD status. Use of capitation payment of the Puskesmas entirely for payment for health services, which is at least 60% of the capitation, and then support for operational costs of, so the rest will be support for operational costs. It could be cost of medicine, medical services, and also other costs, yeah? But so if you imagine a Puskesmas is getting capitation from BPJS, 60% at least will be for the payment of healthcare services, yeah, additional incentive, and then also others, the rest will be for operational. The amount is determined every year. The DHO proposed and mayor decides, considering allowance received by from local government, health services operation, and also the need for medicine. This is just an example of at the Puskesmas level, at the clinic level, how you would spend and calculate how everybody, each staff, how much they get from the capitation. Yeah. So it depends on the attendance. It depends on the, how long have you been working, some of the points, and the point also what type of, are you a doctor, a dentist, or others, and also what other things that you are doing, and then they just putting a breakdown. So in this case, for instance, out of the 50 million rupiahs that was trying to be allocated, this is sort of the distribution. Yeah. So thank you. So that's hopefully that gives you an overview of the service delivery and financing for primary healthcare on the government side, and happy to discuss further. Thank you.
Thank you very much, Diane, for that comprehensive presentation. I think it provided a really concise understanding of what is happening there in Indonesia, and probably a lot of our viewers and listeners here are realizing the parallelisms between. Uh, we have had a number of questions in the chat, so probably later on we'll provide an opportunity for answer them. But also feel free to type your answer to the question. So I'll just speak about the questions that were posted. What is environmental health service? Um, Asking for a copy of the minimum standards of service. How are the locations of the catchment areas of the facility selected? And what are some of the reasons for low absorption rates for beyond COVID? Doc Dian, that's okay for you to answer while proceed with the next part of discussion. Right.
Yeah.
Yeah, thank you. We appreciate the presentation, and now we will provide an opportunity for reaction. And we have a very special combination in our panel, finding both our local experts and international experts to speak about their insights from the presentation that you provided, also some realizations from experience in the of systems, and to provide us with the initial insights from this, we have here Dr. Jacqueline Montpellier, who specializes in the field of public health leadership and governance, focused on local health systems and organizational. Currently, she is the Provincial Health Officer of Agusan del Sur, and since 2008, she championed reforms on systems and processes enhancement, human resource and health for health development, health system integration, budget for health increase, and collaboration with health leaders. She was part of the Zwillig Family Foundation between 2015 to 2008, where she has worked with leaders espousing practice of bridging leadership to improve health systems for better health outcomes. Between 2012 to 2014, she served as an island municipality doctor in the island of Sabtang, Batanes, under the Doctors of the Barrios program of the Department. She is currently the Secretary of the Philippine Society of Health Physicians, Vice President of the Alliance for Improving Health Outcomes, and the Assistant Treasurer of the Provincial Health Officers Association of the Philippines. So let us hear the insights of Dr. Jackie Mo.
Good afternoon from the land of golden opportunities, Agusan del Sur. Am I heard clearly? Because there's challenges on
Yes,
internet.
coming in
Okay.
clear.
Okay. So for our part here, listening from Dr. Dian Kazuma, thank you for your sharing. I can see some similarities and also differences. So in terms of the Philippine setting, how we are organized, our structure, and leadership and governance, there are similarities and differences. So on our part, we have the Department of Health, is the head of agency for health, and they have regional offices and the provincial Department of Health offices. So this has direct oversight to us, no, provincial health office, where I work, and under me, which just no direct supervision, but rather an oversight, the municipal health offices, which I think these are like Pukesmas, is that the correct pronunciation?
Yes.
And we also have the barangay health station. So for the Philippines, with the recent approval of the universal health care last 2019, the role of the provincial health office has been highlighted. We have 82 of that. and our city and municipal health offices is 1,494 across the Philippines. And with this, I've seen how your structure is very clear, how the um, leadership and organization is translated from top to bottom. Uh, while ours is we have like a district because we also have interlocal health zones or what we call or district health zones in some provinces, but not all provinces because as our law says, health is devolved. So sometimes there is disparity across the provinces of the Philippines because that's what the law says, and as well as the Department of Health also espouse the autonomy of the local government units. Um, Also, the difference is our ministry, like your Ministry of Health versus ours is the Department of Health. Sometimes they go directly as well to the different levels. So the provincial health office, they connect, and then at times they will connect directly to the municipalities or the local government units under our oversight. And also, I've seen that your district health office is the lead or the supervision is under the for the hospital. I mean, the supervision for the hospital is under the district health office. For our case, it's quite different because there are provinces that the provincial health office is the direct oversight of the hospital, but there are also provinces that the hospital is like a parallel entity to the provincial health office. It's not under the provincial health office. So it's quite challenging as I've talked to the provincial health officer who are heads of the provincial health office. They find it challenging for those design of the structure that the hospital is a parallel to the provincial health office. So that's the difference I've seen in terms of the leadership governance and the structure. Second, you were mentioning about the minimum standard of service. I've seen that there are similarities actually because you are very strong on the promotive preventive side, and I've seen that your approach, it's like a life stage approach because you have grouped the what you call this the services by depending on the type of patient in terms of age, with focus on non-communicable diseases and infectious diseases such as TB and HIV. So some sort of similar, this is our similarity. But what struck me the most is that referral is a part of your service. So from your end, did I get it right that referral is a service? On our end, referral is a system. So I think it's really good that we also consider it that referral is actually a service to be offered to the people. In terms of Philippines as well, we have there's this administration that focused to the age group before, but I think recently we have I'm not sure, but I just felt it from the ground that we have backtrack it, the life stage approach, and return to programmatic approach just recently. So on our part, actually, we will really follow the mandate of the national while still ensuring that what's applicable to our context, we apply it. In terms of the human resource for health, we have similar problems actually. We also lack doctors, laboratory professionals, and most especially dentists and pharmacists. And currently, we have programs to address the lack of doctors and nurses, maybe a little for the laboratory specialists, but not so much on the pharmacists. So that's for the HRH, and very similar for the HRH challenges. For spending for health, I've seen that you allocated to regions for this operational expenditure. And I think what I appreciate about how you did the budgeting, you have a technical criteria, which I think will ensure the biases. But to be honest, in our country, it's like our budgeting is, yeah, this is an honest comment, okay? It's political, to be honest. I'm not sure if there's a criteria. It depends how you fight for your budget. And it depends on the flavor of the political climate, and also as well, not just political, those elected official, but also political in terms of the current managers of the bureaucracy. So I guess that's what can I share to your presentation, and thank you for this opportunity. Back to you, Mike.
Thank you very much, Doc Jackie. I think that those were very insightful points, and I'm sure that Dr. Dian is also trying to ruminate his responses to what you have said, because I think these are very good points. In particular, I really appreciated the candor that you provided when it comes to the budgeting system and how it has somewhat remained political and subjective based on your observations within the Philippines, and how Indonesia has actually made changes to make it a more technical system budgeting. Later, probably will the responses from Ian. But I think in good timing, as we now build up on what you have said, we have here our experts provide their insights in response to what Dr. Tian Kusuma has presented. And first of our line of experts, of course, is Dr. Eduardo Banzon, or what we call Dodo Banzon, who is our principal health specialist in the Human and Social Development Sectors Group of the Asian Development Bank. And he is the honorary visiting associate professor, the National University of Singapore Sosvi Hawk School of Public Health. And before joining ADB in 2014, he was the president and CEO of the Philippine Health Insurance Corporation, and he was the regional advisor for health financing for the Eastern Mediterranean region of the World Health Organization, and has worked as well as the health economist for Bangladesh and a senior health specialist in the East Asia and the Pacific for the World Bank. Let's welcome Dr.
Okay, thanks, Mix. Hi, Diane. How are you? Uh,
Hi, Dodo. Thank you.
so, first of all, thanks for the presentation. Really, very benefit, comprehensive, and of course to Jackie, Agusan. Agusan is part of Mindanao. That's actually where they think Jackie's in charge of the Agusan Marsh, right? So it's one of the most one of the few wetlands that we have. Before I will talk about what's in the slides, I probably would just like to highlight the point that you talk about, which is the MPS. And probably I'm doing this because Anton Ku, Dr. Ku from the Department of Health is in the session. And what MPS is actually doing is that first it's issued by the Ministry of Home Affairs. It's not a health thing. That means it's an obligation of all local governments that they should deliver these services, or else they will be held accountable. They will be suspended, or probably even other sanctions will be applied to them. And that's probably what's missing in the Philippines. In the Philippines, decentralization basically becomes like sort of local governments, and that's what Jackie was talking in Agusan. In a sense, they can get away with not delivering the services. Because although it's written in the law, there's no explicit instructions from the one that supervised them, which in the Philippines, the Department of Interior Local Governments, that they should provide this because it's a minimum standard of services. The second element that needs to be highlighted is that this delivery of services is monitored by the Ministry of Health. So it's the technical team, the Ministry of Health, that do the supervision. But it's the Ministry of Home Affairs that mandates that. So I hope that this is something which is not found in the Philippines, but in Indonesia. Just like probably also to highlight, and I think if you see these slides, or and thanks to Pak Iri, Iri's not here, Satyawan, also a friend of ours, and you know Iri, right? Dian. And basically, I think as for those who are here, those from the different countries, it basically highlights the fact that complicated financing, and I'll probably shift to financing of health services at the local level is not unique to a particular country. Sometimes countries would love to present their own particular concern that they have fragmented health financing system. It's apparently it's common, and it's really, in a sense, it's a remnant of the realities of the time. A lot of the health reforms, you know, I don't think anywhere in Southeast Asia or even in Asia Pacific, you were able really to consolidate among developing countries, consolidate funding in one source. Even our friends from Thailand have a separate funding stream for those that are in the government or in the private sector. So in the sense, having this multiple funding of health programs is something, you know, you live with, and you simply try to make sure that it is as efficient as possible. Because to expect, for example, that budget would be integrated with insurance, or national budget and local budget will be one, you know, it's quite difficult. I don't think it, in a sense, we just like to emphasize this complicated slides, which whenever you talk about other countries as well, even Vietnam, even Philippines, you also have a similar complicated diagram. So just like the fact. Next slide, please. Sorry. Sarah, you're on board. Now, this is quite interesting because in a sense, this is probably something Dian talked about. That capitation is generally designed as per member, but there's a difference between the type of facility. Okay, so in a sense, this is a recognition that you could not have your facility, you cannot have common facilities, and you probably need to adjust the capitation rate. I think in the Philippines, there's a big debate now between private sector and public. There's supposed to be a higher capitation rate for private, but it is still, you know, an ongoing debate. So I think the experience of Indonesia on how they actually made this aggregate, how do we call it, differentiated capitation level is something that enlighten. Now, if we look at the Thai, I'm sorry, I don't have the slides here, how the Thais are doing it in their UC, similarly, they have this level of, they also have different levels dependent on the service, historical services being provided, and the population and the risk. So in a sense, this sometimes they call this risk rating, but this is also in a sense based on facility level or facility capacity. Now, what's interesting is that, okay, so this is the, I don't think Dian showed this, but these are the services, the enumerated services, okay? And I think there is, this was updated quite recently, but there are, of course, details on what is part of this. So in a sense, in the Philippines, this is also a similar thing. I think even Indonesia has it. But quite interesting here is how in so-called public health programs, immunization, family planning, stunting, and screening are actually part of what's in the what's supposed to be covered by capitation. So it's a very so in a sense, you don't need really to focus on individual services. You could actually bring in other programs. Now, the next slide is more interesting. Next slide, because in Indonesia, I think Dian can talk more about it. At the primary care facility, or what they call FTKL, there's actually services paid by our friends from the health insurance that is paid by case rate or fee schedule, or whatever you want to call it. So in addition to the capitation, there are additional services that can be provided and paid by their version of PhilHealth, BPJSK, okay, VSS in Indonesia, in Vietnam, where you actually get in, so, and this is designed because you are either having services that's difficult to incorporate as part of the capitated services because they're different to calculate, right? They're not really that usual, your routine, or you want to promote certain services. So if you look at number 3, sorry, I have that in yellow, testing for chronic disease management, because this is a priority of the government, they made it, in a sense, fee schedule, blood glucose, HbA1c, blood chem. Screening program, IVA is a screening program for ADHD. So this is a priority of the government. Pap smear, rectal touch, that's the British, that's the It's a more British term. It's the Indonesian term for rectal digital exam. So these are also paid, cryotherapy for cervical cancer, and so on. So essentially, the message here is that you don't need to pay everything by capitation, but you could also have a mix, have a blend. Indonesia has reached that point that they're blending. Now the question is, will Philippines be ready for that? Next slide, please. Now, how the capitation is paid. So they have moved away from traditional paying per person, but actually into what we call a performance-based capitation. It was also presented by Dian. I just probably want to show a little bit, and probably Dian can discuss this later, that there are, in a sense, 3 indicators. So our KBK is capitation. So please excuse us, there's always acronyms when we do presentations in Indonesia. And in a sense, this, so it's like this indicators will become sort of a factor when you get, so the core calculation is still per person. So imagine like 10,000, right? But how much you get, whether it's 100% or 70%, will be based on this performance. So in a sense, this it's driving the puskesmas or the primary care facility to provide services as they are obliged to do. Because the risk you have with capitation is because, and we everybody knows about this risk, is there's a tendency of providers not to provide the service. So what are the indicators? Contact rate, non-specialist referral rate, and okay, next slide, please. You'll get a copy of this, but in a sense, what they'll do is that there are calculations of how it's done. So, so you still have, look at the denominator, total registered members. So that's how those who are familiar with how it's done in the Philippines with PhilHealth, that's total registered. Then you have other denominators, which really, in a sense, force the puskesmas or the primary care providers or the health center or the RHU in the Philippines, if this is adopted, to make sure that they're actually doing a good job of tracking everyone. Next slide. Then this will end up into something like this. Look at the weight, assessment value. Don't want to complicate you, but in a sense, next slide. It basically shows that your assessment value, that was the last column, and sorry, this was copied from our friends, is that you need to have a 4 to get the 100%. If you're less than a 4, you get a lower amount, okay? It's not that bad. 85% is the lowest. If you go back, previous slide, please. The assessment value is the last column, right? So that means you need to have a score there that's based out of a weight and a target, okay? So essentially, it's driving you to perform. Next slide. And this is probably a key difference in how capitation is being paid now in Indonesia. Next slide. And how it's now the last part, and I think this is sorry, Joseph is here. My favorite, disbursement. How does, in a sense, the payment's done? Okay. Where does the payment go? So as you have heard from Dian, if you are a blood, what's a blood? A blood means it's again an Indonesian acronym. Sorry, I don't have it in the slide. Essentially means you're financially autonomous. You've been assessed and evaluated and determined to be capable of handling, to have financial autonomy. You could actually keep your money. So if you're a blood, the money goes to you directly. If you're a non-blood, it goes to the local government. So here, basically showing it's more of the local government. Now, what is key? If it's the money goes to you directly, if you're a blood, then you control the money, right? Essentially, you then have to provide that services on your own. If you're non-blood, the money still does not disappear because the money will be part of the budget of the local government, but it is tagged as something that has to be spent for health. Now, that's a key concern that has always been raised with the Philippines with the capitation payments of PhilHealth, that once it goes to the general fund, then it sort of disappears because you never know whether it's going to be used for health. In this case, Indonesia basically allows that for local governments that are not blood, but they make sure that the money is actually tagged. Next slide, please. And there's a very powerful message that the capitation should only be used for health services, right? And that it should not be used for other things. So very similar to the thinking that's happening now in the Philippines. Last slide. So we go back here now. And frankly, sorry, I missed discussing. But another thing that's missing, and that's quite interesting, and sorry, I got lazy here, is that in Indonesia, the duck, and there was a big discussion on the duck non-physics. So duck is not just non-physics, it's also physics. So DAC is essentially money. So imagine the Philippines, you have your ERA, right? So ERA is black grants, or you can see the slide, black grant DAO, ERA, right? That's the money that goes to local governments, and they can use it whatever they want to use it. It's their money. Now, so DAC is essentially money, and of course you still have local government. DAC is money from the Ministry of Finance. It goes to the local government, but it will only be used for what it's specified for. So as this is presented by Dian, so the DAC non-physics essentially should be used only for health, and with focus on objectives of the government, which include tobacco control and NCD. The physical DAC will also be used for equipment, health equipment that already been requested and approved and has to be signed off by the Ministry of Health. So local governments cannot just say, I want a PET scan or whatever interesting machine. It has to be something that's already been cleared, I think, in advance by the Ministry of Health. So this is something that is not present in the Philippines. So in the Philippines, you don't have this process of DAC or non-DAC. Well, in a sense, there's really nothing in the Philippines that have national government giving something to local government that is specific for something. So this is something that may be explored. Now, what's interesting, of course, as we showed, the health insurance is similar to BPJSK. The national budget is like the DOH, Department of Health. Essentially, just like in Indonesia, Philippines do HFEP, this health facility, capital investment. So Indonesia also do that. So for Papua, it's sometimes the Ministry of Health that spend the money to build the facilities because they recognize that that cannot be built by the by the local government. Or in a loan that we're working on, the Ministry of Health actually bought ultrasounds and anthropometric kits on their own and distributed it to all puskesmas ultrasounds and to the Posyandu's anthropometric kits. I have the international donors there in yellow because there's also another loan, about $4 billion paid by about 4 banks. And it's providing equipment to puskesmas, and not just puskesmas, even local government labs and private hospitals. Now, of course, the whole discussion on HR is something I'll probably leave to the other speakers, but there are also similar concerns in both. Philippines having a bigger problem because the outmigration of Filipino health workers is probably more significant than Indonesia, but Indonesia is also losing a lot of health workers to Australia. They're not a US market, they're more the Australian market. And of course, in Europe. So although it's not as severe in the Philippines, because the Filipinos are all taught in English, the problem of outmigration is not something unique to the Philippines. So concerns about bringing up more health workers is something that's an ongoing challenge also, including something common to both countries, which is doctors refusing task shifting, right? Doctors refusing non-doctors to do things. So it's interesting to hear, I think, the Philippine government today announced that they would like RadTech out of grade senior high school, and all that, and all that. Finally, Dian talked about the Posyandu scheme, in a sense, sub-village. So it's really below the village. And it's interesting to hear, of course, the Philippine government today announced a plan of what they call Purok Kalusugan. Purok in Filipino, Dian, and to everyone who don't speak Filipino, means village as well. Smaller than the barangay. Barangay is the more bigger. There's also, Kalusugan, of course, is sehat, is health in Filipino. So it's quite interesting that there are similarities also on how solutions are being thought of by government in ensuring universal healthcare. So I'll stop there. Thank you.
Thank you very much, Doc Dodo, for that insightful construction of what you understood from both our situations and both Indonesia and the Philippines. And I think even Dian is nodding a while ago and when he was listening to what you have said. And it really provides us a clearer context of what we need to understand and learn from in terms of our experiences, both being decentralized countries and making the changes for primary healthcare. And to proceed with some more insights from our experts, we have another one. To provide her insights, we have Dr. Pura Angela, or Piwi, who is a health policy and health systems expert with around 15 years of experience in development research, advocacy, management, and leadership of various health and development organizations. She's currently the country director of ThinkWell, International Health Systems Development Organization, works to improve health outcomes in low and countries. Over to you, Dr.
Thank you, Max, and our ADB colleagues for the chance to give insight on the topic, and congratulations to Dian for an excellent and detailed presentation. Also, Doc Dodo for those additional information, difficult act to follow. And to our participants, good morning, good afternoon, and good evening, and I hope you learned a lot as I did. This is actually an area that we've been working on closely at ThinkWell through SP4 PhD project. So in particular, the Philippine team and Indonesian team, but also other countries such as Pakistan, Kenya, Burkina Faso, and Uganda, were lucky to learn from each other through this project. As Mike and Dian mentioned, though, there's actually a lot of similarities between the context of the Philippines and Indonesia. Both are low middle income countries, both are decentralized, both have mixed health financing system with an NHI, but also with tax-based inputs to health financing. So both are also in the middle of reforms to achieve universal health coverage, especially through strengthening primary healthcare. So in terms of the Indonesian reforms, as these are actually similar thoughts in terms of Doc Dodo. So there are a lot in terms of what the Philippines and other countries can learn from. So in particular about BPJSK's payment for primary healthcare, again, the system is not purely capitation, but is actually blended. So there are also some case payments being paid to facilities. But what's interesting is that there's a difference in terms of how capitation is paid, so that it's actually linked to efforts to provide health services and ensure performance rather than paying only for empanelment of population. So even if it's performance-based, however, there's flexibility in their criteria to ensure equity in payment for GIDA or remote areas. So I've been talking with a PhilHealth colleague, and she's very interested to learn further in terms of this. So what's also interesting about Indonesia is that they're not relying purely on PhilHealth. So in terms of the DAC payment as well, or the national transfers or budget for health, so it's actually linked to priorities and performance as well. So it's not just a grant allocation. There's flexibility, but again, there's an expectation just in terms of performance as well. And also just in terms of this, there's actually engagement with the PFM system and ensuring that there's actually alignment in terms of this process. What's also interesting about Indonesia is about the BLUD and the non-BLUD facilities. And these are actually reforms in how facilities can directly utilize funding rather than rely mainly on the subnational unit. So the BLUD facilities have additional flexibility in terms of how they use the funds. They're able to use this for operational costs, as Doc Dodo mentioned, but additionally, the BLUD facilities can actually use this to hire contractual workers. So this ensures the responsiveness to health needs and financial signals of these facilities. And at the global level, actually, there's much interest in terms of this. And it's interesting to see and learn from how Indonesia is implementing this reform. So actually, it's not only the SHI payment, which the BLUD facilities can use. It's also the user fees, which they can also collect and ensure that they're able to use this to add to the inputs that their facilities need. So even with these reforms, however, I know that Indonesia actually continues to see new challenges arising. For example, even with these financing reforms, there's actually some documentation in terms of continued challenges to ensure reliability of availability of medicines, or even things such as designing performance systems or dashboards to ensure that the subnational units or even the facilities are able to meet health targets as well. So challenges that I know our Indonesian colleagues are already thinking of how to address. And looking at the questions in the chat box, I think the countries are also interested to learn from each other, even at the more operational level in terms of this. So I hope our ADB colleagues will also continue to facilitate these learnings, while we at ThinkWell will continue to see how we can document and illustrate these reforms so that countries are actually learning and improving their financing of primary health care service, and even beyond this, their whole health system. So thank you.
Thank you very much, PV, for providing us your insights and also posting a challenge to the ADB in documenting and illustrating the reforms that are happening, especially and now that we're discussing the changes that are happening within East Asia. Now we have the opportunity for us to open the floor for questions and answers, and we have been receiving a number of questions already. Uh, for this, maybe I could ask Doc Dian to probably choose the question that he wants to address first before we proceed with calling up one of our audience here who will later ask his questions directly. Doc Dian, is there a question that you wanted to address?
Yes,
Thank you.
thank you, Dr. Michael. And thank you again for the comments and additional information from Dr. Jackie, Dr. Dodo, and Dr. Peewee. So yeah, so in terms of the questions from the chat, I'll try to do it from the top maybe as quickly as much as I can. What is environmental health service? So that includes at the district level, that includes the supervision of restaurants and to make sure that they are up to the standards. So they're a unit at the district health office, and sometimes they work together with an officer at the Puskesmas level to do a survey in terms of the helpfulness of the food providers. Yeah, so that's one of the examples. Another example would be checking in air pollution in the area, water pollution, and things like that. Another question from Tirtha Sinha is, could you share the copy of minimum standard of services? Yes, I think that's possible. It's publicly available as well, provided that you can translate it to English if you're not reading Bahasa. How's the location of catchment area of facility selected? So yeah, so in terms of the Puskesmas, it will be based on the sub-district. That will be the first one. And then if that sub-district is determined by the local government to based on the needs and population that needs 2 or 3 Puskesmas, and then the local government would define how is the catchment area for each one. And then under Puskesmas itself, the catchment area, if they decided to have another auxiliary Puskesmas or a pollen desk, like a village midwives, they would the Puskesmas will be in discussion with the local government and the district health office and the local government in terms of how they determine the location. Yeah. So what are some of the reasons of low absorption rates beyond COVID? Yeah, I think it's part of it is because everybody is so busy with other things. And I remember, at least in the case of Indonesia, like for instance, like diagnosing, tracking, diagnose, testing it, at some point earlier in the pandemic, the government is really trying to getting support, not just from the district health office, but also from the Puskesmas level. So you would imagine additional task that is being being asked to them, potentially part of it as all the national challenges that I provided on the slides, like maternal health, child health, tuberculosis, even non-communicable disease, tobacco control, are all sort of put, if not on hold, maybe on pause, because everybody's doing COVID basically. So I think part of that's part of the reason why the absorption is quite different during that period. Are there any instances where capitation prepayment are not fully utilized by the other one? How much is the percentage share of DICA vis-a-vis PPGS capitation? Not sure about the percentage share, but in terms of the actual amount, it's actually quite similar. So I just if you remember my slide in 2021 or 22, I think the budget is about 10,000 billion rupiahs, and in the special fund DACA non-physical is actually about the same. It's about 12,000 billion rupiah.
Yeah.
So
12 billion.
yeah. So it's quite the same in terms of that. And then if you're asking in terms of DAK non-physical, but DAK that's DAK non-physical for health, yeah. But for all the DAK non-physical, is, so DIK non-physical for health is only 10% of the total DIK non-physical. So you would imagine 90% would be done on DIK non-physical for education, for something related to economy, gender equity, and others.
All right.
Yes.
Doc, thank you for answering those questions. Probably later, because the subsequent questions will also align probably with the question that will be provided by our next
That's good. Thank you.
member here. May I call on Director Ku, who is currently the Director of the Bureau of Local Health Systems at the Department of Health, to ask some questions for you.
Hello,
Doc
good
Ku?
afternoon. Can you hear me?
Yes.
Yes.
Okay, thank you. First and foremost, thank you, Dr. Dian, for the very comprehensive presentation of Indonesia's health system and health financing mechanism. I learned quite a lot from your presentation. It's very interesting how different funding streams actually work because from what I've studied, mostly they're talking about a single stream of financing for the health sector. Also, thank you for the panelists and other reactors for further providing insight into the presentation. First, I have some question from the presentation, and I hope you can enlighten me further. I take note, actually, Doc Dodo has already highlighted this earlier. I take note of the difference in capitation for the different levels of health facility, including a difference of capitation rate for the public and the private. So a very significant difference actually. So how do you align that with the number of registration? Provided there are for private clinicians, for private clinic, I think they can go as high as 15,000 rupiah, whereas in the other health facility, they only pay around 4,000 rupiah. So how do you choose or how do you make sure that a lot of people will still go to this, or not everyone will choose to go to the private facilities? The registration.
Thank you, Dr. Anton. Yeah, so as I shown in the slides, and I think Dodo also provided in terms of yeah, so I don't have any like a direct answer to that, I think, because the data is showing that about 70% of people are registered at Puskesmas, BPJS members, and so for those who probably don't have the who have strong preference to be under the clinic, for instance, so that will be registered under a clinic, or I suppose if so I think it's preference from the participants, but I think the government is encouraging people as much as possible to register to the Puskesmas. But in case that maybe Puskesmas is either not available or they have strong preference to clinic, I think that is the case, that they will be registered to the clinic, and then then BPJS is then cover them. Yeah. Okay. I don't know if that answers your question. Yeah. Or
thank you. I just have a follow-up question because it will matter. So if some people will have the preference for the private clinic, but based on your statistics, there's still a lot who goes to the Puskesmas. Is there a difference in the premium that they pay for the health insurance if they choose to get registered in a private institution versus those that chooses to remain engaged or registered in a public institution?
So at the scope that we're talking about today is at the primary healthcare level.
Yes,
so
yes.
there's no difference in that sense. However, if we are talking about hospital or inpatient care, So that is where people usually, if you're paying the premium at this a level, it's like level 3 of hospital care, so you will have to pay, or level 1 or VIP, you will be in a certain bracket of premium. Although there is I think a more recent discussion or it happened, if I need to check whether it has been implemented, is that Indonesia wants to sort of remove all the classes in terms of even the hospital care, so everybody will sort of like if you are in the UK, you can imagine, you don't, unless you pay for private care, non-NHS, you will get basically like, you don't get to choose, I want to be in the one bed in one room. You just have to be assigned. So you don't have that sort of stratification in terms of, so towards something like that in the case of Indonesia. But I need to check again whether it has something that has been implemented. But in terms of primary care, there's no such thing, Dr. Anton.
Okay, thank you for that.
Thank
So
you.
I'm assuming because there is no difference in the premium that people registered in public facilities and private facilities are paying, there is also no difference in the level of services that these two types of facilities are providing.
Yes.
The last questions that I'd like to ask is if the payment mechanism or the capitation is prospective or advance payment, and I take note also that it's being given on a monthly basis. How is the um, National Insurance Corporation of Indonesia able to monthly process all those payments? That is a very efficient mechanism to be able to process all this claims and all this financing on a monthly basis with the number of health facility that you have shown us.
Yes, thank you. So I think it's paid in advance. So I think it's prospective in that sense, and it is monthly payment. I think part of it is because it depends on it relies on the massive network that BPJS has at the district level as well. So all the district has a branch of BPJS. I think it's something similar in the Philippines. And when you talk about, although if you talk about Indonesia and say both Puskesmas as the government clinic and private, maybe we talking about 10,000, 20,000 facilities. But if you're talking about district, it's a different story. So for instance, in a city, you would probably find they have 30 Puskesmas or 50 Puskesmas, and that's already quite a medium to large city. So if you look at the district level, it's not that massive in terms of the numbers. Does it make sense? So hopefully that gives you a perspective of how they manage to do this.
Okay, thank you. That clarifies everything because I was thinking they were paying individual the Pokesmas, but they're paying at the district level, and then the districts distribute the monies to the different
Yes, even though the money is coming down all the way from Jakarta as the central because at least all the calculation and everything like that will be handled by the local branch. Yeah.
Okay. Thank you so much for all those clarification. I'm learning a lot from your lecture.
Thank
Thank
you.
you. Thank you, Dr. Ko. Doc Dian, at least we have Dr. Ko here who's also at the forefront of the reforms that have to happen with regards to the things that you have presented. And we're glad that he's been posting very challenging questions for us to think about within the region. We also would like to put attention to some of the other questions that were posted. Primarily, it was talking about capitation and in various fronts, no, on how capitation is going to be created in various gradations to really create the necessary behavior incentives. How do you do that? And also, how are you managing any remaining unused capitation? And how are you monitoring or utilizing your capitation payments? Do you have any answers to these questions?
So I don't have the data. I found the data in terms of the utilization or absorption for the DAK non-physical, but unfortunately I need to do a bit more digging in terms of the absorption for the capitation and what happens. But I would imagine that it will be quite good in terms of the absorption, because one is that 60%, at least 60% is spent on a staff incentive. So that at least 60%, so that could go all the way to potentially most of that. And then they have a simple Excel that can basically basically calculate how much everyone sort of get incentivized in terms of the staff. And then in addition to that, so there will be maybe about it could be about 10 to 20% of that funding could be spent on others, which when we talk about Puskesmas level, this is where the action is, isn't it? So you would imagine that, and as highly, as I was mentioning in one of the slides, even for the national government, one of the on the various challenges of in terms of delivering primary health care, when one of them is resources, and I think it's what Dodo and others mentioned as well in the Philippines. So if they have some funding, at least at the Puskesmas level, if it's not something that is very stringent in terms of how to spend it, I think it will be something that will be easily spent at the Puskesmas level. And again, bear in mind that this is where the action is, and this is they know exactly what they need. They know exactly how many. They are the ones who are meeting the patients. So if they're giving incentive to their staff, it's something that is related to their day to day. So I would imagine and also part of it is because they have they're doing it monthly, and as Dodo was adding, they have the performance indicator as well in terms of the capitation. So I think they will be trying very hard to make that as close as possible to 100%, if not more. Yeah.
Thank you. You mentioned flexibilities, and these are the things that I think I also agree with that, as we now try to make sure that the funds are actually used, and also this is something that is really a big quandary for a lot of our LGUs and for the national, because as we now try to look at what can be spent, flexibilities are always being requested, especially within a decentralized setup. So apart from those, what do you think would be the useful tools, the policies that have been used by Indonesia to really to really be effective and efficient in attaining primary healthcare and universal healthcare within your country?
Thank you, Dr. Mike. I think one of the things that I just wanted to highlight again, what Dodo mentioned, in a decentralized system, it is a decentralized setting like Indonesia. The fact that we know that at the local level we have it has been the devolution is making it that the health policy and other policy at the local level, at the LGU is in the Philippines or the district level in Indonesia, is the responsibility of the local government, right? Now, if we're talking about primary healthcare at that level, at the district level, if the standard minimum standard of services, for instance, is coming from Ministry of Health, it will speak in terms of gravity. It will be a bit different from what they have now with the SPM coming from the Ministry of Home Affairs, because on a regular basis, all the mayors, all the head of the district, they are accountable to the Ministry of Home Affairs. So they are answered to them before, and then Minister of Home Affairs and other ministers are answering to the president. in this case. So it's really a powerful tool. Just a simple, who is this regulation of SPM is coming from? If it's coming from Ministry of Health, okay, Ministry of Health doesn't really have that much power at the local level, at least now that we have a decentralized system for the health sector. But Ministry of Home Affairs is. I think that's one of the key thing. And then another aspect for that would be you can imagine that a mayor is reading this SPM, so they start reading not just about education or economy, but also reading child maternal health, child mortality, hypertension for elderly. This is the mayor reading them, so it's quite powerful in the sense of child health in terms of stunting. Is quite powerful at that level. Non-health people reading something about health indicators, isn't it? So, and they know that this is something that they have to report to their boss, which is the Minister of Home Affairs, right? So it gets really in terms of Dr. Mike, you mentioned about political support and everything like that. So it really gets to that. And one of the good example is stunting. So stunting has been so all this while stunting has been like a problem, like a health problem. Now in Indonesia, stunting and I think is part of the report that I provided to ADB, how the stunting relates to this whole architecture of Puskesmas and others at the district level, is that because stunting is now the priority of the mayor, so all the efforts, all the money, all the sectors has to support that, not just the district health office or Puskesmas. So that also creates another powerful push in terms of all the challenges. So imagine doing that for maternal mortality, even imagine doing that for obesity, even or tobacco control. So that's quite quite powerful. So some of the things, although is a bit maybe a bit subtle, but it gives some powerful implication to what's happening at the local level, especially in a decentralized setting like Indonesia and the Philippines.
Thank you, Dian. I think that was inspiring for us, at least in the Philippines, as we now see the parallelisms, and the Home Affairs is also akin to the Department of Interior and local government, and recognizing the powers that have been decentralized to the mayors to be responsible for health, and it's in managing this relationship between the ministry and also the LGUs would be pivotal in actually making the changes for health. But I also would want to, because one of the interesting things that you have posted, that you have presented is the idea of the BLU. And one of the challenges here in the Philippines is utilizing performance accountability tools to drive changes in health. And I think BLUD is to some extent a performance accountability disbursement mechanism, looking at the capacities of the various organized networks to really dispense money on their own. Am I right? Am I right in this assumption?
Yes.
I would like to pose this question to Doc Dodo Banzon and also Dr. Piwi. Do you think something like this performance account, this assessment of the capacities of networks to handle their own money, is this something that we can really apply here in the Philippines as well?
Mix blood. Sorry, BLU is not just a health thing.
It's the overall capacity of the government, local government.
It's financial autonomy of government units. Okay.
Okay.
So in a sense, what they said is that look, any government unit, if you are capable, you become a blood. Okay, so hospitals can become a blood, schools can become a blood, and so on. So it's not a network thing. It's at the facility level. So in a sense, so imagine in the Philippines, RHUs becomes blood, right? Or the city health office, or so that's the comparison. So and all the provincial hospitals becomes blood. Now to become a blood, and I love using this acronym, blood, right? Not because of what it sounds. The facility is mandated to build financial capacity, management capacity. right? That means you're not just so in a sense everybody becomes comfortable that they can manage the money.
Mhm.
Now there was one thing, and allow me this, and this was something very interesting that I think we missed talking about this, Dian. Accreditation. Okay. So in Indonesia, all the government facility is also has to go to an accreditation process managed by the Ministry of Health. Okay, so it's the Ministry of Health will check on every facility, and the accreditation process is quite comprehensive. Now, what's the nice link here? You could not be contracted by the health insurance, BPJSK, unless you are accredited. So everybody now wants to be accredited. So it's not the accreditation is not driven by the health insurance. So in the case of PhilHealth doing it, but it's the Ministry of Accreditation process. And once you are accredited by the Ministry of Health, you get contracted. Now, what's the ongoing discussion? It has many levels, 1, 2, 3, 4, right? Something like that. So now the rule, the rule is only level 1, you're okay. And so now the push is that if you go higher, you get more money. So that's an ongoing discussion. I think a third part, sorry, Dian, if allow me. Something also Dian talked about, which is a little different from the Philippines, but it's quite interesting. The Philippines and Indonesia are known worldwide because these are the two countries that did a single fund. Okay, our friends from Thailand never did it. Our friends from Thailand separated their in the poor or the non-formal under the UCS. And the government scheme is separate and the private sector scheme is separate. So in effect, they don't have the clamor coming from the well-off or the rich. That is the dilemma of the Philippines and Indonesia, right? Because they were single funds in Asia. So, and if you look at South Asia, their scheme is for the poor, BPL. So the scheme in India, Pakistan, all that. And the well-off, they leave them to their, in a sense, what your traditional Medicare program is in the Philippines. So in the Philippines, and Vietnam is not single fund. They mix the fund, but they also have separate schemes for population groups. So it's the Philippines and Indonesia that's struggling with this. The Indonesian approach, historically, they always have this 1, 2, 3. That means if you are a director up, like Boku or Klem, you are VIP and your premium is higher. So that's why they have class 1, 2, 3. And those that are subsidized by the government is class 3. And if you are subsidized by the government, you could not use a private room. You could not use a VIP room. Okay. So that's now the Philippines, it's all the same, right? And there's no difference in your room. And the ongoing discussion that what Dian is saying is that in Indonesia, this is being challenged because it's considered to be inequitable. And so there's an ongoing discussion now that the class 1 to 3 will become only a single class. Now, this approach of 1 to 3 is actually common in other formal health insurance schemes in North Africa, in the Middle East. This sort of a European model that was adopted by a number of countries. Indonesia is more Dutch, right? Philippines followed some country across the Pacific, right, called Hollywood. No, sorry, United States. So in a sense, so the Philippines approach is the 1 to 3 is never been. It's quite interesting that in the Philippines, this demand for a VIP package is now on the table. Okay, so in a sense, it's quite interesting to see all of this. Now, of course, the Philippine solution is to create a separate fund called PhilHealth Plus or whatever you call it, right? Or in effect, de facto, it's already been created with all these private sector HMO plans. But also Indonesia have these HMOs because there are also people there who still wants better VIP services than what the ministry, than what JKN can happen. But these are in a sense probably just probably adding more details to what was discussed by Dian on yeah, I'll stop there.
Thanks, Doc. Doc Tiwi, do you have anything to add to what Doc Do has said?
Uh, right now, I'm actually doing the analysis in terms of our cross-country work in terms of facility financing. What we're learning actually is we're not actually starting from scratch. So our primary care facilities are actually receiving petty cash, and this is what they actually use to purchase emergency medicines. Um, But at the same time, we have to go back in terms of what we're trying to address. In terms of what Jackie is saying, it may be that there's really just this, lack of capacity, but at the same time, the accountability to ensure that the money is actually being utilized for health services rather than something that undergoes a very political process. So if we need to strengthen our systems, we need to ensure that we're designing it in terms of what goal we have in mind. What we're also learning right now is that we can actually separate the types of costs that we need to pay for. So as Doc Dodo was sort of telling us earlier, infrastructure is something that's better paid or processed at the more national level using our HFEP, if not at the facility level, maybe at the provincial level, planning for it. So thinking of how we can be able to do it. Then at the HR level, we also have to acknowledge things like the PS cap. So how can we just address that? At the for medicines, for example, there's some value just in terms of pooling, especially for GIDA areas, to ensure that there's efficiency. So separating that, but ensuring that if there are sudden emergencies, facilities can be able to tap their petty cash so that they're able to provide the services for the patient, not stopping them, not ensuring that they're paying out of pocket in terms of this. So we have to think of that. We have to think how we're able to strengthen our system. And then we're actually reviewing, there's actually an ongoing draft of an MOP right now to address some of these are actually a bit complicated. So example, we have to ensure that facilities are actually in the chart of accounts so that they're able to process the funds, they're able to be accountable for it. Then, of course, to strengthen the capacity of the facilities, there's actually a need to be able to train those facilities and ensure that they're able to forecast, to ensure that they're able to input this in their system. They have access to the IFMIS so that COA will be able to view what they paid for. We have to also ensure that there will be no corruption involved to strengthen those systems. The PFM stakeholders are our friends as well, so we have to be able to tap them and work with them. So that's it, Mike.
Thanks, Pee. Those are helpful, and hopefully we are taking notes, and some of our people are also taking notes. And hopefully, Doc Dian, this experience is also becoming mutually beneficial as you learn more and more about the Philippines. So now, before we proceed with closing our session, of course, we would want to hear some more comments or insights. Firstly, from Doc Jackie Monville, and then after Doc Jackie, would it be okay for you, Diane, to provide us some closing insights from your end? Doc Jackie?
Thank you, Mike. Actually, I would like to second Doc Banson and Dr. Ko with regards to maybe we should have more capacity building for our local health managers in terms of financing. That's really important, especially on the part of forecasting, procurement, and maybe thinking out of the box methodologies to secure the steady flow of supply chain management logistics, such as the medicines and the medical supplies. Because I think it's a perennial problem here in the Philippines in across all health facilities, the lack of medicines. We have services, but we don't have the commodities to support these services. And also maybe I think we need to be more what do you call this, facilitative to the how we finance primary healthcare facilities, because from experience it's always easier to the hospitals always easier to receive those national or PhilHealth reimbursement vis-a-vis the primary care facilities, which are the rural health units. So I think that's what I'm going to add to also ensure that we strike a balance of incentivizing and financing the primary care and the hospitals, because honestly majority of our budget is still hospital. Yeah, I have yet to see that there's a balance between the two. Thank you.
Maraming salamat, Jackie. Over to Doc Dian. Doc Dian.
Thank you so much, Dr. Michael, and also the other panels for the comments. And I think what we know is that the national priorities in Indonesia and the Philippines are very similar, and also along with other countries in the region like Thai and Vietnam that Dr. Dodo was mentioning. You know, it's improving life expectancy, reducing maternal death, reducing child death, child stunting, you know, tackling infectious disease, now tackling a non-communicable disease, and you know, focusing on primary healthcare is one of the key you know, key component that a country can be focusing on, and within that primary healthcare, improving the service delivery and financing through especially through learning from what other countries are doing. And I think I second what Dr. PB was mentioning. Part of it is also about documenting what and also assessing and you know, showing what other countries with you know, can learn from each other. And I think that's especially in the region. But I think that will be one of the you know, beneficial things to do. And then I think through this the next few sessions with the ADB Secure, I think you know, all of us will be learning from one another, and hopefully that's for the improvement of delivering primary healthcare in the country, in our country, and in the region as well. Thank you, Dr. Mike.
Terima kasih, Dian.
Terima kasih.
All right. And as we close this session, we thank our speakers and also the members of the panel and all those that have attended, and all those that are remaining. Thank you. Basically, the supporters of devolution who see that if devolution is handled well, it will actually provide systematic participation and autonomy to a lot of our providers and hopefully better responsiveness. But the recent challenges that our countries are facing, we have seen that there is heightened vulnerability in our systems, and there's a high knowledge and design requirement to really address the misalignments, the premature delegation, and also fragmentation and loosened accountability in a decentralized setup. And the parallelisms that we have seen based on these discussions between Indonesia and the Philippines calls our attention to the health system design, the designs that we are making to circumvent the effects of decentralization, and also understand the mix of our providers, which are both public and private. And what Indonesia has provided us is some inspiration around the organizational clarity that they have achieved and more defined services and minimum standards that their country has been doing. And of course, they face similar challenges of inadequacies, both in human resource, drugs and equipment, budget, and also quality. And their intention to revitalize their systems through financing reforms, like the DAC, is something that we can learn from, and the work of through the BPJS Kesehatan. And they've also resolved a number of transitional operational challenges, including defining the technical criteria for budgeting that moves away from very political and subjective methods of budget allocations, the Puskesmas accounts, and also the defined computational requirements, having referral as part of the required services and not just part of a system, and having Irengar as part of their info system that provides planning and allocation, that defines their planning and allocation, and having those performance-based payments within the Puskesmas that actually facilitates the implementation of the objectives of the health system. And all these things that we're really learning from this exchange. And essentially, in light of the ASEAN Economic Community and the integration of what we're learning within the Southeast Asia, our governments are actually looking at changing their role, not just as a provider of health, but now becoming a regulator of health. And also for Philippines and Indonesia, having a single payer is a common challenge that we're trying to create and anticipate in the design of our system. And it goes without saying that the improvement of our social health insurance system is something that we really need to work on for both our countries. and learning from each other would only accelerate our process. And with that, I support the statement of Dr. Angela Ko for that we here at ADB would welcome all these things to learn from and document and illustrate the development that is happening within the East Asian region. And we also invite you to our second webinar, Getting Public and Private Sector work together towards integrated primary care. And here we will learn lessons from Singapore, and it will happen on June 27, 2024. And with that, we thank you for attending our webinar.